As such, on the differential, most likely is acute diverticulitis. This is most likely considering the left lower quadrant pain and tenderness, elevated WBC count, possibly from eating popcorn, the CD food hypothesis, the mass on physical exam on the lower left quadrant, and the appearance of the diverticuli on the abdominal CT. However, it would be most likely that this diverticuli would have been chronicled in past examinations, particularly during his workup of his colon cancer 4 years ago. Other diagnoses on the differential, less likely relapse of the colorectal cancer or possibly metastasis to the liver. However, this is less likely considering there was no jaundice secondary to liver mets, no palpable mass or blood or mucus in the stools. It was not an iron deficiency anemia, but most likely anemia of chronic disease, as the iron panels were normal. The liver function tests were also normal, and the barium enema and CT were also unremarkable for relapse of the colorectal cancer or METs. Acute appendicitis was also less likely, considering the location of the pain, left as opposed to being right. However, it should be noted that because he had part of his colon resected, the anatomy might be altered. However, he's also in an older age group, and he has had this pain for 2 weeks, as opposed to a more acute onset of 2 to 3 days usually. Again, imaging was unremarkable with this respect. An inguinal hernia is also less likely, considering there were no masses noted in the region of the groin on physical exam. Gastroenteritis was considered, considering the elevated WBC with neutrophilia, suggesting a bacterial nature. However, stool cultures again demonstrated was negative. Intussusception might be possible considering the post-op adhesions that can occur. However, the pain was not intermittent or episodic, but rather progressive, and also imaging showed otherwise. Intestinal obstruction and constipation might have been possible, considering again the colon surgery. However, he experienced multiple episodes of loose stools, and normal patency was demonstrated on the barium enema. As for plan, for the acute diverticulitis, acutely we want to give him bowel rest, either by just fluids or nil by mouth. If the pain does worsen and becomes very severe, opioid analgesics are advised. Antibiotics, we should give him a standard regimen of 7 to 10 days of ciprofloxacin and metronidazole. If the diverticulitis does not improve, then we should probably consider surgical intervention. As for prevention of future recurrence of this diverticulitis, we should again emphasize the importance of a high fiber diet and exercise, and maybe we could try suggesting a food other than popcorn, though the CD food hypothesis is a bit controversial. As for the lack of appetite and weight loss, if they become very severe and he continues to lose weight, we should consider an antiemetic. For the piriformis syndrome causing the radiating left pain, we should first attempt conservative treatments, which include stretching exercises and physical therapy. If these do not work, once the diverticulitis passes, then NSAIDs can be used to maintain, I guess, or control the acute exacerbations of this pain. As for the colorectal cancer, we have not completely ruled this out yet. So first, what we need to do is we need to get the baseline CEA from his oncologist just to compare our current values. And then, once the diverticulitis has passed, a colonoscopy might be recommended. As for the anemia, we want to monitor his blood work to see how the anemia might progress. As of yet, he doesn't present symptoms other than fatigue. If the fatigue persists after diverticulitis has passed, then further blood work is warranted. That should be it. Again, Dr. McCarthy, if you have any questions, feel free to email me, and thank you again so much. Have a good day.